Pediatric mechanical circulatory support. Mechanical circulatory support for infants and children is largely distinct from that of the adult population. Importantly, the pediatric uh, mechanical support is most commonly used to bridge the heart transplantation and is accomplished with one of the several clinically available VADS devices. The technology of the pediatric VAD is maturing, and several medium and long-term devices are available. However, no durable device is destination therapy exists for smaller children, and the majority of the pediatric patients supported by VAD cannot be discharged home. The development of the pediatric VAD continues to be limited to challenges related to the miniaturization of the devices for this population. Among the VAD implanted in the recent years, there are support to bridge to decision 38% and 8% are bridge to recovery. 1% of patients under 19 receive VAD as destination therapy in the similar period. As most of the VADs are implanted by bridge to transplantation or bridge to decision, the majority of the patients receiving the VAD will have end-stage heart failure refractory to maximal medical therapy. The most common etiologies for the heart failure requiring the pediatric VAD are dilated cardiomyopathy and congenital heart disease, with the remainder of the patient implanted for myocarditis or restrictive or hypertrophic cardiomyopathies. Composed to their adult counterparts, pediatric patients undergoing VAD implantation are more critically ill at the time of the implantation, and 30% of the patients with Intermax Profile 1 and 50% with Profile 2 and 13% Profile 3. Only 2% categorized at Profile 4 to 7. Particularly vulnerable population patients supported by VADs for the congenital heart disease tend to be younger, smaller, and sicker than the other pediatric heart failure patient with a greater population of Intermax Profile 1 and the greater frequency of the liver dysfunction at the time of implantation. Utilization of the VAD support has increased tremendously as the VAD technologies and practices have developed over the last 2 decades. VADs used at the time of the transplant increases 13.1 for transplant recipient in 26 to 28% to 28% in 2016 to 19. This is now preferred method of bridge to transplantation circulatory support for infant and children, as VADs have demonstrated early and late survival benefit over the extracorporeal membrane oxygenation for the support and indication. VADs used in the pediatric population may be categorized between the paracorporeal, pulsatile, paracorporeal, continuous, and intracorporeal continuous flow devices. Paracorporeal pulsatile devices are preferred for the long-term support if greater than a few weeks of circulatory support is anticipated. Berlin Heart X-Core is the pneumatically driven paracorporeal pulsatile device and has accumulated the most experience to date for the pediatric bridge to transplantation. X-Core remains the only FDA-approved MCS device for bridge to transplantation for neonates, infants, and small children, and may have been implanted into the patient between 3 to 60 kg, aided by availability in a wide range of sizes, and it also has benefit of providing isolated left or right ventricular support as well as biventricular support. Other paracorporeal pulsatile devices include the Biomed and Thoracotech, which have gathered limited clinical experience. Paracorporeal continuous flow devices are suitable for short-term support 1 or 2 weeks. These devices are centrifugal pumps in a simple circuit without an oxygenator such as Thoratec, Pendimag, and Centrimag, and they can be applied for isolated left or right ventricular support and are beneficial for the ease of covering them to VA ECMO with the oxygenator in case of impaired pulmonary function, and PC devices are often used in infant with small children as a short-term support to bridge to decision and bridge to bridge with a later exchange to long-term VAD to await transplantation. And the few selected centers, these devices are used in conjunction with Berlin heart cannula and all the way to transplant. Intracorporeal continuous devices employ either axial or centrifugal flow pumps that provide the isolated left ventricular support. Intracorporeal implantation can facilitate discharge home and associated significantly with the device infection compared to PPC and PCC device. All intracorporeal devices are adult devices, and no device has yet miniaturized for infant and young children. However, the experience in accumulating the off-label intracorporeal LVAD implantation in children with body surface area of as low as 0.7 meters or weight as low as 17 kg. The, the hardware HVAD is most widely used device and shown multi-center retrospective study to allow 60% pediatric patient to be discharged home after implantation. The patient receiving the intracorporeal devices are not only older than the larger and those receiving PPC and PC device, but they also tend to be less critically ill and less frequently categorized as intermax profile 1 and less frequently have congenital heart disease and have less renal liver dysfunction at the time of implantation. The indication for the use of VADS in young children are infant more than 3 kgs who are candidates for cardiac transplant, also have severe biventricular dysfunction, severe isolated left ventricular dysfunction, and a need of mechanical circulatory support as bridge to cardiac transplant and recovery. The Berlin X-core may be implanted in a similar fashion to adult LVAD with some additional consideration. The first is skin sites, the two cannula exits, and should be marked so that each cannula exists at least 2 centimeters below the costal margin and at least 1 centimeter of the Dacron cuff externalized from the skin. Some surgeons prefer to create a cannula tunnels from the skin prior to heparinization. Cannulation strategy involves distal ascending aortic cannulation and leaving sufficient room for LVAD outflow cannula on the ascending aorta and bicaval venous cannulation to facilitate any intracardiac procedure. The right atrial cannulation should be BiVAD support and necessary. The left heart should be vented through the right superior pulmonary vein and the VAD may be implanted under the cardioplegic arrest or the beating heart. The inflow cannula is implanted first with the LV apex, which is scored out just anterior to the vortex. After implantation, such a plagiated horizontal matrix suture, it is externalized through the previously created skin tunnel. The aortic cannula is brought throughout the other skin tunnel prior to implantation in the ascending aorta, which is accomplished either by complete aortic occlusion or with a partial occlusion clamp depending on the size of the aorta and outflow cannula. The aortic cannula or the smaller patient may be placed within the two concentric purse string sutures and that are then brought up through the flange of the cannula at the opposing side for the smaller patients in whom the ascending aorta or even the smaller aortic cannula is inserted with 8 to 10 Dacron grafts sutured to the ascending aorta. In the larger patient, the cannula is sewn and the standard end to side vascular anastomosis. The de-airing is accomplished by first venting the heart through the aortic cannula, and the device is then de-aired by attaching the blood pump to the cannulas and aspirating from the pump chamber with the pre-mounted blunt de-airing needle. After separation of bypass, the blood pump is examined to assess the LVAD filling, and if the excursion of diaphragm in the blood pump is inadequate, attention is paid to correcting hypovolemia or supporting the RV function, and inhaled nitric oxide and inotropes. If the RV function remains inadequate, cardiopulmonary bypass is reestablished for cannulation of the RVAD support. The pulmonary artery cannula is passed through the body wall and then attached to the distal main pulmonary artery in the fashion similar to the aortic cannula. The inflow cannula is placed in the right atrium inside the two concentric purse string sutures brought through the flange of the cannula at opposing side. Flows are reducing on cardiopulmonary bypass to allow the right heart and cannulas to fill for de-airing. The pump chamber is then de-aired with the blunt needle and the patient is separated from bypass. Complete separation of the heart is required for the implantation of the VAD into the to prevent the right and left shunting of LVAD suction of the PCN IC devices. If the ventricular chamber is small and is restrictive cardiomyopathy, the left atrial cannulation may be necessary for LVAD inflow. Severe aortic valve incompetence should be addressed at the time of the VAD implantation, although MRTR does not necessarily need to be repaired at the time of the VAD implantation. Tricuspid repair of TR may avoid RVAD support. The VAD support in the univentricular heart is considered as the LVAD with the apical aortic cannulation is successful. The prevention of adhesion formation using the judiciously placed PTFE membrane will allow easier and safer external re-entry at the time of the implantation. Contraindications: not a candidate for cardiac transplant, inability to tolerate systemic anticoagulation, anticipate the need for MRI, presence of mechanical aortic valve, and special population changes with single ventricular physiology. Postoperative goal is to stabilization and long-term mobility, growth and development, and family-centered. The following outcomes are provided by one of the registries. The overall survival of the patient who remain on VAD support at 6 months is 74%, 73% of the cardiomyopathy patient and 56% of congenital heart disease patient who successfully bridged to transplantation. Most common adverse event after VAD implantation are neurologic dysfunction and multi-system organ failure. Berlin Heart X-Core device has gathered the most experience to date for bridge to transplantation. Therapies involving to standardize aggressive anticoagulation with promising preliminary result and the improved stroke rate to 11%. Thank you.